Name is Arthur. Hello, everyone. My name is Arthur Ohannessian, and I'm very excited to present to you guys today, along with my colleagues, Dr. Garo Harmandayan and Dr. Julio Meza. Before we begin, I want to go over some disclaimer slides here. This is our CME committee for the AAMS. You guys know many of these individuals, and I'm sure some of you already know these folks very well. The talk that we're going to be giving today is specifically going to be regarding the new DEA licensing requirement for CME education for all DEA licensed providers, specifically regarding the treatment and management of patients with on opioids or on substance abuse disorders. And so we're gonna do kind of like a three-part presentation. I'm gonna start off by giving a little bit more historical context about the current opioid epidemic and some of the government and regulatory changes that have happened over the past 20, 30 years, and also some of the clinical guidance that's changed during that time. Dr. Harmandayan will then pick up from there and talk specifically more about safe opioid prescribing, as well as how to assess for pain, and also really focus on some non-opioid therapies. And finally, Dr. Julio Meza is going to take the last leg here, and he's going to cover in some more detail regarding some of our newer medications and treatments for substance use disorder, things like Suboxone and naltrexone. And so we're very excited to present to you all today. And this is all of our bios, which I'm sure you guys can take your time to read, but you guys don't need me to go over. We'll just jump right in here. So let me switch off my slide deck. Excuse me one moment. All right, there we go. All right. So again, welcome everyone to our talk here, and we'll start off by stating any disclosures. Myself, Dr. Meza, and Dr. Harmandayan do not have any commercial or private interest to share. These are some of the institutions and organizations I work for, UCLA, as well as the Los Angeles Department of Health Services. Our learning objectives today are going to be, we're going to examine some of the factors that led to the epidemic of opioid addiction in the US. We're going to go over what the new DEA requirement is regarding 8 hours of training for substance use disorder as well as opioids. We're going to introduce some safe opioid prescribing tools and some non-opioid treatments for chronic pain. Again, that portion is going to be reviewed in more detail by Dr. Harmandayan. And finally, Dr. Meza is going to talk to us about some new evidence-based treatments for opioid addiction as well as substance use disorders. So I know this is not something that is maybe new information for anyone, but I think it's important for us to understand the gravity of the problem. I'm sure many of you are all aware of the opioid crisis that we have in the United States. In the past 2 years, in 2020 and 2021, which are the years we have data for, we're still waiting for the 2022 data to be finalized. But you could see that we've had almost 70 to 80,000 reported overdose deaths. And this rate is actually still increasing, and the total number keeps increasing. And the large proportion of these overdose deaths are due to things like prescription opioids, heroin, and the biggest culprits in the last 5 years have been synthetic opioids, things like fentanyl, as well as now carfentanil, which is even more stronger than fentanyl and more dangerous. How did we get here? Some of you might have remember me from talks I gave back in 2019, where I was really trying to share with you some of our new guidance regarding naloxone and some of the regulatory requirements regarding its distribution for patients on high-dose opioids. Well, I do think it's important to give us all the historical context of how we got here. So, you know, if you went back to the 80s and 90s, a lot of the medical community was, under the impression that we are really under-treating pain, and that pain is a human rights issue. And there was actually very good data supporting that. Historically, communities that are marginalized, especially specifically African-American women, were really neglected in terms of their pain treatments. folks were considered and vilified as being drug seeking and, not being honest or truthful regarding their complaints of pain. And so there was a big push for us to rethink and for the medical community to reassess and really focus on pain even being what they called the fifth vital sign, something that was really promoted by the American Pain Society. And early data and expert opinion really were supportive of opioids use chronically. There was a very famous New England Journal article in 1980 where it basically said that the development of addiction is rare in medical patients with no history of addiction. In 86, Portnoy put out some evidence saying that opioids maintenance therapy can be very safe and a reasonable approach to chronic pain. And the Joint Commission, which obviously is a regulatory body for all hospitals in 2000, said that there's no evidence that addiction is a significant issue when a person is given opioids for pain control. Now, I'm sure all of you guys also remember, when the marketing that came from the drug companies, these are some ads when Vicodin was still proprietary and, it was marketed as this miracle medication that, takes you from your knees to standing up. In 1996, Purdue Pharmaceuticals famously brought out OxyContin, and there was this huge push regarding chronic opioids to be even used for things like osteoarthritis and chronic pain. Fast forward another 10 years after some of that, like I said, medical community as well as marketing campaigns, and we saw a huge expansion in the number of opioids being prescribed. It was almost quadrupled over 4 years. And as the US, we're only 5% of the world's size in terms of population, but we consume 75% of the world's prescription drugs, and opioids being a huge part of that. Now, as this rise happened, we started seeing these signals of increased overdose. We obviously started having a reaction from government and as well as regulatory agencies. The CDC declared that the opioid epidemic and addiction is an epidemic in 2011. Later on in 2014, Attorney General started saying that heroin overdose were an urgent public health crisis. Then in 2016, the Surgeon General put out a huge commitment regarding the pledge, regarding safe opioid prescribing habits and giving some more clear guidance to providers about how to limit some of the opioid prescriptions that they provide. And finally, in 2017, it was formally declared a public health emergency. And at that point, it was common knowledge in terms of the public too, that opioids are a real big problem. Then we had the reaction, right? So regulatory agencies are starting to crack down on doctors, and the pharmaceutical agencies are now getting hit with $6 billion judgments. Purdue Pharmaceutical largely went bankrupt because of this large judgment. The Sackler family, which was the main proprietors of and owners of Purdue Pharmaceuticals, became basically a scarlet letter where they were big donors to museums, to medical schools. Their name was removed from all those buildings. And so there was this real vilification almost of opioids and the rampant prescription of them. And so this is actually a graphic that's going to be changing as I'm speaking. This is from the CDC. And what you're seeing here is over time, as the states turn more red, you are seeing more and more prescription of opioids per 100 person capita. And as you see right here in 2013 or 2014, you start seeing this lightning where the CDC information, the regulatory crackdown, it's really having an effect. And you're seeing now prescribers are prescribing it less and less all throughout the country. There is also a lot of public campaigns regarding educating folks regarding the risks of opioids. So, we in some ways succeeded, right, in really trying to limit and rein back maybe some overprescribing. So in theory, the overdose deaths and the epidemic should be getting better as well. But this is the data I have to show you. This is the total number of opioid overdoses for each year in the US. And as you can see, even though I just showed you a graphic showing that the prescribing habits for providers really have changed, the overdose rates just keep increasing. And I alluded to this prior that, a large part of this sharp increase also are some of these newer synthetic opioids like fentanyl and carfentanil. And their, I would say, distribution in the illicit market is really what's really causing this newer spike. But one thing that or an area that we really want to focus some of our talks on as well, and something that maybe we have some more local control over, is that in the past 5 to 6 years, there's been a big push from the CDC, as well as addiction medicine programs, and NGOs, regarding trying to educate providers on some of these newer treatments, such as buprenorphine, and some of these new substance use disorder medications that we have, that are really trying to attack the problem of addiction. The challenge, though, that we've been seeing for the past 5 years or so, is that the regulation regarding being able to prescribe those medications was so onerous that even though they were available, and we now have evidence that they're much safer to use and going to have some more broad applicability, we just weren't getting enough providers to be able to actually prescribe them. It was largely, addiction folks and pain specialists were the ones most comfortable, and specifically was something called the X waiver license. And so I'm going to go back here and give you some more context too of what the X waiver license was, because it now no longer exists. And I think this is a very important distinction to make. So let's move back to the 1970s, where the Health and Human Services, which is ultimately the regulatory agency from the feds, said that methadone, which was one of our first treatment modalities for opioid addiction, specifically was designed more for heroin addiction, that we're going to create a very tight regulated system regarding this medication and its treatment, meaning we're going to create what's called a closed system. A closed system meaning that there has to be some special licensure that the prescriber needs to have and register with the DEA. There will have to be, they could only be given in specific clinics, or not even clinics, but specific designated opioid treatment centers. And in many ways, what this did is it really kind of narrowed the number of folks that not only felt comfortable, but were actually even allowed from a regulatory standpoint to really address these issues of rampant addiction. And so fast forward to 2000, an X waiver was established. And the whole point of the X waiver was actually something to potentially broaden and relieve some of these restrictions. What the X waiver did said, okay, we're going to create this extra special DEA license for folks to be able to prescribe these newer medications like buprenorphine to patients in clinics, and not necessarily only in an opioid treatment center. So this was relatively a big change, and it was this broadening of access in some ways. However, let's go now 20 years forward. The number of X waiver registrants were such a small fraction of the total number of opioid prescribers that essentially for the past 2 to 3 years, almost all of the specialty groups, as well as some of the patient advocacy groups, have really been lobbying the federal government and the DEA to really remove the X waiver. And this was mostly because the amount of effort that we were trying to put in to get folks to be X waivers licensed really was not, it was really becoming a hindrance. And the truth is, and Dr. Meza is going to go in more detail later, some of these newer medications are even safer than some of our classic opioids, and especially things like long-acting and short-acting opioids, which almost any provider or all providers can prescribe with their normal DEA license. And so in some ways, it was also counterintuitive. We were creating this extra regulation and almost making these medications have almost this like scary, third rail by creating this X waiver, that essentially the consensus opinion was this really should be removed. And this is actually just a barrier, and it's not actually creating more safety for patients. It's actually causing patients to be more in danger by limiting the number of providers that can actually safely prescribe these medications. So finally, we get to 2023, and we had the omnibus bill, which I don't know if you guys remember was at the end of last year. It was the big spending package that needed to be passed. The debt limit needed to be passed. And part of all that big spending bill was also what's called the MATE Act, okay, which is the medication, the Medication Access and Training Expansion Act. And what this did is it essentially removed the X waiver completely. So the X waiver license that I just talked to you about doesn't exist anymore. And in its place, what it said is we're going to now ask all our DEA licensed practitioners to have some formal education regarding opioids as well as substance use disorders, And as long as they get that education, we are now gonna, their full license is now gonna cover even these medications such as buprenorphine. Now, this regulation applies to all DEA registered practitioners. The only exception is veterinarians. So when I say, all providers, we're including dentists, PAs, NPs. The deadline for satisfying this new training began, I should say, in June 27 of 2023. However, you might not have actually experienced yet because you will experience it when you try to renew your DEA license. This next renewal, that whatever timeline that is for you specifically, you are going to see this new checkbox that you're going to have to check off saying that you attest to having up to 8 hours of training in the treatment and management of patients with opioids or substance use disorder. Now, there are some caveats here. There are groups of practitioners that have already met this requirement. So who are those folks? Those are going to be board certified addiction medicine and addiction psychiatry specialists, because it's part of their board certification to have this training. So if they have that board certification, they will automatically have this requirement fulfilled. Also, any new graduates, anyone who's basically graduated within the last 5 years, and again, this includes medical students, PA students, MP students. If you've graduated in the last 5 years, you also meet this standard. Why? Because all the curriculum in LCME curriculum now has opioid management as well as substance use disorder education built into the curriculum. So that also, if you're a new grad, you're also banked in here. But a large swath of us, are not new grads, and most of you here at this conference are here to basically get those updates and to understand what these new regulations are. And so for the vast majority of us who are going to renew our licenses in the next year or two, and if we haven't had prior education in these areas, we are going to have to get 8 hours of training on this material. To be clear too, for our dentists and our dental practitioners in the audience, pharmacologic management for dental pain and screening, as well as brief intervention and referral to appropriate patients, as well as knowing how to assess for risk of developing opioid or other substance use disorders, are also part of what's considered satisfactory in terms of this training. The training does not have to occur in one session, so it can be cumulative across, as long as it totals a total of 8 hours. Past trainings that you've done also count towards this, as long as, again, they encompass those topics. And any past data waiver trainings count as well. These are folks who maybe already got their X waivers. Those types of training also already satisfy this requirement. And finally, the DEA has been clear that the education can be done in a variety of settings. It can be a classroom setting, it can be seminars at professional society meetings, which is exactly what you guys are participating today. And finally, virtual offerings as well. And just as an FYI, the presentation you guys are looking at today, as well as the panel discussion that's going to be happening live in Vegas, will satisfy 1.5 CME hours for this. So if you minus that, that would leave you 6.5 hours to go. And so where can you get those extra hours of training? I've done some homework for you guys here. These are all links from professional societies that the DEA has given approval for, that all of these education materials from these organizations do satisfy the requirement. In addition, if you go to this website, it is run by the UCLA Opioid and Stimulant Implementation Support and Training and Technical Assistance Program, which let's just call OASIS TTA for short. And they have a whole series of lectures that you can join online and take and get CME credit for as well. We also have the Providers for Clinical Support System, which again has a whole swath of educational virtual trainings that you could take. So I'm giving you guys this as resources. You can pick and choose what you think is going to be most applicable for your specific practice setting. But there are a plethora, and many of these are free. Few of them have some small fees entailed, but I really tried to focus on almost all the free activities so that can be as easy as possible for you guys to access. For folks who are waiting on your secret code, the secret code to the talk is Jupiter, the planet Jupiter. So congratulations to all of you for paying attention on that one. And finally, I want to hand off the microphone here and slide deck to Dr. Harmandayan, who is again going to focus a little bit more about and tell us some more detail regarding safe opioid prescribing, as well as some other non-opioid treatments for pain control. I'll stop sharing here and I'll hand it over to Dr. Harmandayan.
Thank you, Dr. Ohannessian. Can you guys hear me?
Yep.
Yep. Okay, perfect. Okay. Let me see if I could do this. Yeah. Okay.
You could try clicking the bottom slideshow, the bottom right corner. See where that zoom slider is? It's right to the left of that. Like if you go down, like the bottom right corner of your screen.
Give me a second again. I apologize.
Sure.
Hold on one more time. Okay. Let's do Okay, what are
So you see the bottom right corner where you see that zoom slider?
no?
Um,
It is not popping up.
or I mean, or you can also, I think if you go to the,
Is it working now?
there you go. Yes.
Perfect. Perfect.
Yes, this works too. It's giving us a little preview of your next slides as well, and also your notes. I don't know.
Then let's do let's switch it up. Hold
Click on display settings.
Yep.
And yeah, that one, show presenter. That's it.
There you go. Perfect. Yeah, now you got it.
It's working?
Yeah,
okay.
We're seeing
Sorry about that. Apologies. Okay. So I have nothing to disclose. Sorry, my name is Garo, Dr. Harmandayan. I'm a palliative care doc at Cedars-Sinai, a part of the supportive care medicine team. I specialize in cardiac palliative care, but opioids are, I'm very familiar with opioids, and I was kindly asked to give this talk. So we're going to be talking about treating pain and prescribing opioids. So just some general principles for you guys on how to prescribe and when to prescribe. So I have nothing to disclose. Some definitions. So a lot of people confuse tolerance with addiction, but tolerance is when the same dose of a drug given repeatedly produces a reduced biological response. And this happens commonly with opioids. Opioid misuse, taking opioids in a way other than prescribing or patient behaviors that raise a red flag that may indicate the patient is developing opioid use disorder. And then opioid use disorder, OUD, is a brain disease that is not under the control of the patient. It is a DSM-5 definition, and it defines it as a problematic pattern of opioid use leading to clinically significant impairment or distress. So the term, just to put it out there, the term addiction or drug abuser or abuse are stigmatizing and pejorative and connotes blame. And it's recommended that we don't use these terms anymore, that opioid use disorder is the preferred term now. So this is the DSM-5 criteria. I'm not going to go over it, but there's mild, moderate, and severe opioid use disorder. And these are each box is considered 1 point. So treating pain. This is general treatment of pain. You want to make some general principles. You want to make a thorough assessment. You want to build a therapeutic relationship, and then start off with non-pharmacological therapies if you can, and then non-opioid therapies, and then really, in terms of therapies, your last resort is going to be opioids. So assessment, you want to make a thorough pain assessment, and the things that you want to think about are asking your patients to characterize their pain. Is it sharp? Is it dull? Is it crampy? You want to localize the pain. You want to see where it radiates. What's an aggravating or alleviating factors. Ask about the intensity. A 0 to 10 scale is usually what we do, and it's good to keep records of it. 0 being no pain, 10 being the most pain they've ever had. And then temporal characteristics as well. And you want to make a functional assessment. You want to make a functional assessment. You want to make sure, are they walking? Are they not walking? What is the pain preventing them from doing? You want to get a proper pain management history. What have they taken in the past? What has worked? What have they done? Have they had any surgeries? Review the thorough medication history of all their medications. Mental health and substance use history, if they have any, a thorough physical exam, and diagnostic testing if it's indicated. So building a relationship with your patients who have pain or who have chronic pain is very, very important. This is a severe condition that your patients are going through, and it is very debilitating for them. So you want to build trust, and developing trust through good communication, identifying what the patient wants, what is their agenda, how is it affecting their life, and focus on specific examples and explore. Creating a safe space, provide a non-judgmental environment. That is very, very important. A lot of times our patients come in talking about pain, and it's very easy for the clinician to jump to conclusions and be judgmental, but we want to be as non-judgmental as possible with our patients. Set realistic, concrete, and specific pain expectations and functional goals. So non-pharmacological therapies, cognitive behavioral therapies. If you have the resources, you want to reach out to interdisciplinary team members like your social workers, psychologists, psychiatrists, spiritual care department. These are all going to be helpful in treating that patient's pain. Adaptive coping strategies. So this is when you ask your patient what helps you get through the day despite all this pain. What adjustments do you make throughout your day? Help the patients deal with the situational stressor by potentially eliminating that stressor and find out what those stressors are. Exercise therapy, physical occupational therapy, start off slow and then slowly work their way up to more and more longer and aggressive exercises. But you want to take baby steps at first. Hypnosis or distraction, relaxation, or guided imagery. At Cedars, we're lucky that we have a virtual reality pilot that's going on now in the hospital. We put virtual reality goggles on our patients, and it helps, and it takes them to a more calming, relaxing place. And we're getting some good results in terms of reducing their pain. And neurostimulation, so TENS or acupuncture. So other things to consider. So non-opioid pain management, you have Tylenol, you have your NSAIDs, anti-epileptics, so specifically gabapentin and pregabalin. Antidepressants, SNRIs and TCAs are usually the go-to. SNRIs are now the gold standard. Corticosteroids, muscle relaxants, interventional pain procedures, so spinal injections, nerve blocks, trigger point injections. And even though there's limited evidence, medical cannabis. This is something to consider before opioids. This is not your first go-to drug, but it's something to consider before opioids. So prescribing opioids. Now you've tried all those things and your patient is still in severe pain. They're complaining, hey doc, I'm in so much pain. And you think, given the history, given all the information you have, given all the evidence you have, you feel that opioids are going to be the next best thing for your patients. Again, it should not be your first line therapy for chronic pain or any pain for that matter. And opioids work for some people, but their harm is real. Long-term opioid analgesia is associated with an increased risk of developing opioid use disorder. So before prescribing opioids, you want to do the comprehensive function and pain assessment like we talked about before. Assess the risk for opioid use disorder. Check your state's prescription drug monitoring program. Here in California, it's CURES. Discuss the risk of opioid use. Naloxone training and provisions, something that you want to go over your patients before handing them the prescription. And opioid treatment agreement, which I'll go over, but that's not something that you have to do with all your patients, but something to consider for your patients, especially your high-risk patients. So you're assessing risk. How do you do that? Assessing every patient for risk of developing opioid use disorder identifies patients who may misuse opioids, and normalizing that careful oversight is necessary for every patient treated with opioids. You want them to know that you're doing this for all your patients. This is not specific to that specific patient. You want to normalize it. Use clear, non-judgmental language. You don't want to single out your patients. Explore the patient's personal and family history of alcohol or drug use. Inquire into any history of physical, emotional, or sexual abuse. This is a good opioid risk tool that you can easily find online. So the score of 3 or lower indicates a low risk, and a score of 4 to 7 moderate risk, and any score over 8 is high risk for opioid abuse or opioid opioid use disorder. So prescription drug monitoring program, this is something that we check every time we prescribe an opioid, not as an inpatient, but mostly as an outpatient. When the patient comes in as an inpatient, I want to know what their overall prescription history is. And I want to double check what the patient is telling me. And Cures is an amazing resource. And if you're practicing in the United States, this is something that you should most definitely have access to. And every state is a little different. You want to discuss the risk of opioids. You want your patients to be a well-informed patient. You want them to really understand what they're getting into. A lot of prescribing low doses can still cause a lot of these issues in terms of nausea, vomiting, sedation, dizziness, constipation, respiratory depression, hyperalgesia, myoclonus, depression for long-term use can cause depression, tolerance, physical dependencies, and it increases all-cause mortality risk. You want to be very, very careful with your elderly patients as well, or other patients or your patients that have other comorbidities as well. So naloxone training and provision, this is something that we do for all our patients when we're prescribing opioids as an outpatient. So the California law requires prescribers to offer a prescription for naloxone for patients who are receiving 90 milligrams of oral morphine equivalents. OME is oral morphine equivalent per day. And the CDC recommends that you do the same for greater than 50 milligrams of OME. So you want to also counsel your patients about what overdose looks like. It is important to educate the patient and the family and their caregivers. You want the family can be advised on summoning medical help immediately if the patient demonstrates any of the following signs: unconsciousness or inability to awaken, slow or shallow breathing or breathing difficulty, choking sounds, gurgling, snoring noises from a person who cannot be awakened, and when the fingernails or lips turn blue or purple. Opioid treatment agreement. This is also known as a pain contract. I don't know if you guys have done it yourselves with your patient, but this is something that we do with our high-risk patients mainly. And we use it to build trust through communication and set boundaries and share expectations with our patients. They are not designed to be punitive. A lot of the pain contracts or the opioid treatment agreements that existed in the past were a little punitive. Please find something with positive language out there. Potential risk can be detected as a clinician and patient talk through the agreement and review the agreement yearly or every other year. So now you are going to trial the opioids and you want to set clear and realistic goals. Make sure the patient knows that elimination of all pain is not possible. We're going to reduce the pain, and our goal is a functional goal and for the pain to be tolerable, not eliminate the pain. We're not going to get to a zero because that's usually not possible with chronic pain or cancer pain or any other type or other pains that are going to last for a long time. This is different than post-operative pain. I'm talking about pain that's not going to go away. Set long-term functional goals, SMART goals, specific, measurable, action-oriented, realistic, and time-bound. Start slow. If a titration is necessary, stop at the lowest effective dose and avoid unlimited dose escalations, and then be ready to taper. And if you're going to be tapering, and one of the main reasons you're going to taper if like the patient's pain is getting better or they're opioid non-responsive, and there is a small population of individuals that are really not responsive to opioids. And I've seen a few during my practice. Communicate about the strategy with your patient ahead of time so it's not a surprise to them later on. So initial dosing, you want to start slow, you want to start low. So morphine and your intervals on the right-hand side, those intervals are there because that's usually how long PO opioids last for. It's usually how long IVs last for as well. But as an outpatient or in the clinic, you're going to be giving POs, you're not going to be prescribing IVs. So morphine 5 milligrams, hydrocodone 5 milligrams, oxycodone 5 milligrams, and hydromorphine 1 to 2 milligrams. Opioid conversion, this is a general conversion table. I'm not going to go over all of it, but just so you guys know, 2 milligrams of Dilaudid or hydromorphone is equal to 25 milligrams of morphine. I see it a lot as an inpatient where an ER doc or a hospitalist or what have you, they give someone's in pain for cancer pain or whatever it is, and they're opioid naive, and they're getting 1 to 2 milligrams of Dilaudid, of IV Dilaudid. Realize what kind of doses you're giving when you're doing this. A good starting dose for Dilaudid for me, an IV Dilaudid in the hospital, 0.2 for an elderly, 0.5 for someone that doesn't have any other comorbidities and who is not older. So really just start low, and you can always adjust. There's no need to jump to the higher doses. You can start low, let's say 0.2, you can slowly go up. And that also is true for any orals or any opioid. Pharmacokinetics. So IV onset is quick. We're talking minutes. PO, 45 minutes to an hour. Extended release, so OxyContin, MS Contin, those onset is 1 to 2 hours. And the TDF is transdermal fentanyl. That's going to take up to like a day to fully kick in. And when you titrate these medications, with the IVs, you can titrate quickly, because if they're not getting any relief, you can keep adding doses at low doses to make sure you get to a right dose. You can actually stick around and wait in your patient's room if you have the time, if you can, in order to get the dosing right. For oral, every 4 hours, you can slowly increase the dose if need be, if the patient's in severe pain. An extended release, you're really doing this for like your chronic pain patients or your cancer pain patients, and you're doing that every other day, basically. And your transdermal fentanyl, those are 72-hour patches. So you want to give it 2 full cycles before you increase your doses, because that's when it reaches steady state. General opioid management principles for uncontrolled pain, you want to increase it for 25 to 50%. If they're in like severe pain, you can even go a little more, but you really want to be judicious. You can treat persistent pain with around-the-clock short-acting medications, or you can start a long-acting medication, like a fentanyl patch or OxyContin and MS Contin, like I talked about, or even methadone, which I'm not going to get into. But that is another long-acting medication you can start. PRN dose, you really want to have 10 to 15% of your total daily dose. So you just calculate how much they use on total day. And your single PRN dose, you want to be around 10% of what your total daily dose is going to be. And you really never want to give opioids IM. It really doesn't make sense, because you can give it sub-Q. Sub-Q buttons are readily available in every single hospital, or the nurses can give sub-Q injections if you really don't have any IV access. This is a book. This is in the palliative care world. Lynn McPherson is like the godmother of opioids. Her book is amazing. I think this is the best opioid book out there. I just want to put it out there for everyone listening. Patients with opioid misuse. So this is a patient you've been treating for some time, or you're new treating and you feel like they might be misusing opioids, or you're pretty positive that they're doing it, and you're really scared that it might lead to opioid use disorder. So you want to carefully consider whether benefits of opioids outweigh the risk. So are you going to even do it in the first place? Are you going to taper down? You need to like really think about it. And is this the right thing for your patient or not? Initiate a non-confrontational in-person meeting and use a non-judgmental approach. Discuss increased risk of opioid use disorder and overdose with the patient. Provide specific counseling on increased risk of overdose when opioids are combined with other drugs or alcohol. Offer a prescription of naloxone like we talked about, and teach other family members how to use it, or or the caregiver how to use it. Increase frequency of visits and monitoring. You want to use the cures data like we talked about. Now you're seeing your patients every 2 weeks, you're seeing your patients every 4 weeks, and you're keeping your prescriptions within that time period too, right? You're not prescribing a 30-day course, a 60-day course. You're doing 14 days or less, even sometimes, if you're really worried about your patient, and you want to have them count pills and keep track of how many pills they're counting, like have a log. Review or initiate the opioid treatment agreement that you already made or you're gonna now make. Consider drug testing as appropriate to assess for concurrent substance or diversion. present options for referral to a specialist, opioid tapering, or switch to a non-opioid treatment, avoid abandoning the patient or abruptly stopping the opioid prescription. Really terminating your relationship with your patient should really be your last resort, and truly try to understand why this is happening in the first place. Let's not jump to conclusions. Attempt to identify caregivers, family members, and or sponsors who can help assess for aberrant behaviors. You really want the family to come around and help with this whole situation, and maybe they can even help with dispensing some of the medications as well. Consult with any or other healthcare providers who are treating the patient for substance use disorder, including mental health providers or addictionologists, if you have access to them. Misuse can result from different factors. So don't just assume that they're abusing the medications or they have opioid use disorder. You want to really dive in and figure out what's happening. Sometimes it could be from poor health literacy. It could be from misunderstanding of prescribing instructions, cognitive impairment, disease progression. The cancer is getting worse. Undertreated pain, like you started off slow, but it just wasn't enough. An inconsistent or non-availability of medications. Sometimes pharmacies have very strict criteria and they can only prescribe so much. And sometimes they're just picking up half the prescription. Sometimes the pharmacy doesn't have access to it. So you really want to dive in deeper and figure out what's going on and work with the pharmacy that you trust as well. So terminating care, this is really, really the last resort, but sometimes it has to happen. If the decision is made to either terminate opioid therapy or completely terminate care, it is recommended that the patient be notified in writing at least 30 days in advance. You want to protect yourself because there's a shortage of pain management clinicians out there. There really is. And it's a problem throughout the United States in every city. Patients taking long-term opioids for their chronic pain may have difficulty finding a new clinician. Physicians can be held accountable for patient abandonment if medical care is discontinued without allowing adequate provision for subsequent care. The written notification to the patient should include tapering instructions and alternate sources of medical care. These are some important websites, the websites that I use to create this talk, and that's it. That's my piece. Let me stop sharing. Okay. Next up is Julio Meza. He is at UCLA, and he is the fellowship program director for the Addiction Fellowship. And he's going to be talking about buprenorphine used for pain management and for opioid use disorder. Thank you so much, guys.
Thank you very much. Thank you very much for introducing me tonight and for the opportunity that I have to be here. I'm going to share my screen right now. Okay, give me a second. There we go. Okay. Oh, let me just. Okay. I hope everyone can see my screen where my slide is. Is that correct? Okay, perfect. Yep. So definitely, I do not have any disclosures in this case. And as mentioned before, I'm going to be concentrating more than anything speaking in regards to partial opioid agonist therapy with the use of buprenorphine for both chronic pain and opioid use disorder. I'm going to try to dispel some of the most common conceptions that there exist and misconceptions as well in regards to the utilization of buprenorphine. First thing, when it comes to pain, definitely it's important to have always a good scheme in which we are going to evaluate our patients. And in our case, we have adopted this strategy that is called the 4 E's, okay? The first thing is perform a good physical exam and establish a diagnosis, okay? That becomes a primordial thing when it comes to seeing a patient because, for example, some occasions we might throw vague diagnosis to some of our patients like low back pain, right? Or chronic abdominal pain without a specificity, right? And when it comes to the explanation, it might not be able to hold itself to what the patient expects from us, right? And some occasions, we start to have that patient that has multiple ways of thinking, which is like, okay, Dr. Meza doesn't know specifically my diagnosis, right? Am I a medical mystery? Okay. Is it what I read on Google, the real thing on what's going on, right? Does he know what he is treating and so forth and so on? So definitely having a good way to establish a diagnosis is key. Perform all the adequate physical exam maneuvers that might be needed, any other diagnostic tests, and then explain the diagnosis to the patient. Then we go to the portion of execute a plan, right? Are we going to proceed with non-opioid therapy? Are we going to do physical therapy, some other type of non-pharmacological measures that can help to improve patient functioning? And another portion is engage patients, okay? So we need to engage the patient in their own management, because I'll be honest to you, it's true in my case, I am the program director for the Addiction Medicine Fellowship. But whether we like it or not, substance use disorders, especially opioid use disorder, is quite intertwined on some patients with chronic pain as well. Just because a patient has a substance use disorder does not imply that they will never have pain. So it's important to engage the patient, because one of the things and realization that I tend to make my patients aware of when they come to see me is that it's highly unlikely with any treatments that I can render at that moment in time, and even possibly in the near future, their pain scores are going to drop from a 10 out of 10 to a 0, or from an 8 out of 10 to a 0. So definitely want to engage them that we can achieve as much as we can with multiple different maneuvers. And in that way, definitely we're going to concentrate for the most part in quality of life, their improvement, which is going to be marked if we actually perform care in more than just the pharmacological reinvention of their medications. Now, do we use medications? Definitely. So one of the tools that I actually have become more keen on using is actually this really cool tool that I found on this website, and you can see it at the bottom, is paincalculator.com. And what it allows me to show to my patients specifically is, okay, if I was to intervene pharmacologically, what's the potential impact that I'm going to have, right? For example, and I'm going to pick in one of these 3 examples that we see right here. Let's go with chronic low back pain, okay? And definitely it's going to be difficult to make a show of hands right now, but I bet that no one's going to deny that at some point in your life, you've seen someone with chronic low back pain, not neuropathy, not nerve compression, that just point blank low back pain in which gabapentin has been prescribed. If we look at the middle column right there, do we see any gabapentinoids on that column and how effective they may be? Not at all, right? Because definitely gabapentinoids for chronic low back pain, they do nothing. There is no evidence of their use, okay? Where do gabapentinoids play a good role? We can see on the column on the far right, okay, we definitely can see that they play a role on neuropathic pain, but in just point blank chronic low back pain, they will not do much, okay? And this allows me to engage my patient on the potential interventions that I am to make, whether it's to prescribe or even de-prescribe, right? Because gabapentinoids, they come with their own side effects as well, right? Similar situation on the left, right? We can see that intraarticular corticosteroids, they do have some value, SNRIs, oral, NSAIDs, and even when we speak of SNRIs, there is a particularity when it comes to Cymbalta compared to Pristiq as well, or even venlafaxine. So all of them will be slightly different. So why I like to use this tool as a way to explain my patients why some decisions might be made, plus also allows them to make a more informed decision. Another cool feature of the same website is that we can actually play a little scenario with our patients, okay? We can choose, as we can see on the top area, right, the type of pain that we're dealing. Let's say that I'm seeing a patient with neuropathic pain, okay? And I ask them, okay, in a scale from 1 to 10, how severe is your pain at this moment in time? They might tell me, Dr. Meza, it's an 8, as we can see there. Now, with therapy, potentially their pain can improve in between to 5 to 6 out of 10 from an 8, okay? and at least we can start to engage in that potential therapeutic intervention. And at the bottom, we can see, if we're speaking of neuropathic pain, right? If I was to use TCAs, I have more opportunities of improvement. If I use SNRIs, we definitely have 15% chances that they're going to get better, 29% chances in which they might feel about the same, okay? Or some improvement, especially if they control the primary condition that is leading to that neuropathic pain, right? And 56% chances of not improving, okay? Is this a solid number that every single patient is going to react in the same way, shape, or form? Not necessarily, right? The human body is such a complex group of organs, but at least allows me to exemplify to my patients in the sample size and studies that have been made the possibilities of percentages on how much improvement they can receive with the therapy I am offering. But then it comes another portion, right? We establish the diagnosis, we explain the diagnosis to our patients, then we're going to try to take motion into what to do, right? But some occasions, one of the big things that can play a role in how much a patient will be engaged with my therapy is going to be side effects, right? And that's why I like to use this table. It's in the same exact website as well, in which I can show specifically some of the most common side effects and even the cost of the medication, especially if they're looking at that from that standpoint as well. Let's say someone has really slim to non-insurance, definitely it gives them an idea in how much impact financially this may have. So definitely I use this quite often nowadays, just because definitely allows to have that open dialogue with the patient more than just me trying to transfer information from one place to another. Both of us, we can evaluate what we're dealing with in front of us. Now, let's say that we get to a point in which several medications have been tried, okay? The patient for X, Y, or Z reason will be maybe not an ideal candidate to continue on full mu agonist therapy with Norco, oxycodone, Dilaudid, let's call it any name, right? And definitely they might benefit more from buprenorphine. There are formulations of buprenorphine that currently are well approved for pain, and they're well known. One of them is what we see on the top right there, which is what it goes by the brand name of Butrans patches. There is a generic formulation as well now that can be obtained. And the good thing about Butrans patches is, one, that is a patch that will be applied for a total of a week. So the patient does not need to take any medication for a time span of a week. It's quite effective, to be honest. Maybe the first patch is the one that the patient may not notice in fully, because it takes at least 2 to 3 days to take effect. Posterior to that, we start to notice how the medication starts to work, and by day 7, it has plateaued on its effect. Mostly, we can think on Butrans patches to be utilized on patients. For example, if someone is having way too many side effects from Norco or oxycodone, and you want to transition to buprenorphine, is a fair option to attempt, especially if the total dose of milligram morphine equivalent is less than 50. If it's beyond 50, it's highly unlikely we're going to have a good equivalent. On the actual specific website of the brand, Butrans, okay, you can find a really nice calculator that tells you what dose might be a good way to start if someone is on X dose of Norco, or X dose of oxycodone, or X dose of Dilaudid. A lot of my patients like it, especially because of the convenience of not needing to take anything. Some of the potential contraindications is definitely to have some irritation due to the adhesive especially. And one of the big things is that it's ideal not to expose the patch to extremely high temperatures, meaning that if someone loves to go to a sauna, or maybe to go to the jacuzzi, okay, definitely not to get that patch wet with really hot water, because it's going to release all the buprenorphine at once. The most common question patients ask me, can I take a shower, a warm shower? Definitely, okay, we can totally do it, okay, as long as you don't do those showers in which you come completely red. Out of the showers, you're going to be completely fine, okay? And the patch tends not to detach in the presence of water really easy. Now, let's say that some of us definitely would prefer something not necessarily that will be adhered to our skin, and we prefer something that we have more control over. We have also Belbuca, okay? This one is only brand as of right now. There is no existence of any type of generic formulation as of this moment. And Belbuca is a really interesting formulation for one reason. I tend to call it in my clinic that formulation that can bridge me in between what the patch does versus what the Suboxone, as we know it, can do as well. Okay, the reason being the dose. As we can see, the Belbuca formulation can go from as low as 75 micrograms to as high as 900 micrograms, which will be about 1 milligram of buprenorphine. Is really good to utilize. Definitely, it does give a lot of more range for conversion, especially we have someone who's using full mu agonist therapy. Let's say we have someone, just to give an example, on oxycodone, maybe more than 50 milligram morphine equivalents, as I mentioned. The patch may not be a good option. Buprenorphine may, specifically, the formulation we use for opioid use disorder might be too high of a dose. What can we utilize? Belbuca might be a really good option, okay? Now, I often get the question when I prescribe these two, but Dr. Meza, I've read, or my pharmacist in the past, or somebody else that I know told me that if I was to switch from my opioid, I'm going to withdraw if I start this suddenly, if I don't do a proper taper or whatever the case may be. And it's true to an extent. Precipitated withdrawal with buprenorphine, it does exist. I've seen it. It's not fun, okay? Being that said, like everything in medicine, everything depends on the dose, okay? So for example, if someone is taking, just for the sake of numbers in this case, to make a good reference, if someone is taking, let's say, hydrocodone acetaminophen, 325 milligrams, and I want to transition that person to a Belbuca, for example, and 150 micrograms of Belbuca will be the equivalent to that. And the only thing they need to do, they need to go with their daily life as usual, pick up their Belbuca, and the next morning, instead of taking their Norco, now they can take Belbuca instead, 150 micrograms twice a day, and withdrawal will not occur, okay? Because the dose of buprenorphine is not high enough to displace at once all the full mu agonist that still remains on the patient's body. And by the time when the full mu agonist has abandoned the patient's body, we have enough Belbuca to sustain the patient without causing any withdrawal. So it's a really seamless transference when it comes to this medication. Both of them work really well. I've used them quite often. Some occasions, the biggest limitation is knowing that insurances may require prior authorization, but definitely they're really well covered at this point in time. Now, we have some patients that definitely will be on way higher doses, right? I have faced those in my clinic as well, right? I have some patients that they might be on hydromorphone 8 milligrams every 4 hours or every 3 hours, right? On those cases, I'll be completely bluntly honest to you. Belbuca or even the Butrans patches, they will not be beneficial at all. They will not provide enough of the opioid stimulation, one, to prevent withdrawal, and two, to even help with their pain. So on those cases, it's better actually to transition these patients to the formulation that commonly we use for opioid use disorder as well, knowing that we're using it to target pain. How and why it's important to make that difference? One of the classic examples is that buprenorphine tends to be, for the most part, a medication that we take once a day only. Exception on patients with chronic pain. Why is that? The analgesic effect does not have the same duration as the effect to prevent withdrawal. Effect to prevent withdrawal. Buprenorphine is a long-acting agent that works for more than 24 hours. Analgesia, buprenorphine is no better in duration than oxycodone. So we're going to have to dose it 3 to 4 times a day. So, but Dr. Meza, you just said that some occasions we can go into precipitated withdrawal. Is there a way to potentially avoid that? Because it's true, right? When someone decides to go into buprenorphine, especially in the formulations that we commonly use for opioid use disorder, if they go into withdrawal, right, the first thing the patient is going to think, oh, I'm allergic to that thing, don't give it to me anymore, don't want to touch it, okay? So it's when we need to be careful. Now, there will be different schemes to start buprenorphine. You can see them in different journals, okay? There is the initial way in which we used to start buprenorphine before, which is some people call it induction of buprenorphine. I'll be honest with you, I prefer not even to use that word, as Dr. Harmandayan said before. One of the important things is to have the patient engage with us. And how do we do that? By removing this stigmatizing language, right? When I say induction, it sounds like I'm doing something really astrological, something magical, right? And I'm not doing that. I'm just starting an opioid, right? So we never say I'm going to induce you on insulin today or induce you on lisinopril. So it's the same thing here, okay? Because if I say that word, I used to have that thing which patients would look at me kind of odd and definitely felt that it wasn't appropriate. So I just started saying we're going to start on buprenorphine and we're good to go, okay? So that's the first thing that definitely we do. We just explain that we're going to start a different type of opioid that has different benefits. One of them is that it tends to cause less sedation than regular full mu agonists. Second, it has a ceiling effect that reduces the possibility to cause respiratory depression as well. And another thing is that definitely is going to allow the patient to feel awake and still get some pain relief compared with some occasions when the other full mu agonists are being utilized. We tend to be more drowsy and occasionally not being able to engage on activities of daily living. I have an example right here on how we commonly start buprenorphine on patients with opioid use disorder. But believe me, when you get to the point of initiation of buprenorphine, it does not matter if you have a patient with opioid use disorder or a patient with chronic pain. You still can repeat the same scheme with anyone. And that's the reason why we at UCLA, we kind of have steered away from other mechanisms, because this has worked for us for the past 4 years without having any type of precipitated withdrawal. Another thing, trying to be as polite as possible, right? I have looked at different schemes of how to start buprenorphine. And what I find myself some occasions, if I get confused, I not even can memorize those things. So I start to think, right? If I have a patient in front of me who might be in chronic pain, on distress, depressed, and anxious, how likely is that they're going to do calculations that I not even can do when I'm fully sober and feeling well and performing the things that I love? So we try to reduce it in our clinic to a way in which to us buprenorphine should be as easy as take an antibiotic. Example, you tell someone take Keflex, 500 milligrams 4 times a day for 7 days, they take it, and that's it, no issues, right? So in our case, this is the way we start buprenorphine in our clinic. If someone comes and tells me, Dr. Meza, I'm taking my hydromorphone 8 milligrams every 4 hours, every single day, but I want to transition to buprenorphine, what do I do? Simple. You're going to continue your life like nothing, keep taking your hydromorphone, and I'm going to furnish a prescription for buprenorphine to you, in which on day 1, you're going to take half of the film or tablet 4 times a day. So 1 milligram 4 times a day. On day 2, you're going to take 2 milligrams 4 times a day, okay? If it's a patient on chronic pain, I'm going to let them stay at that dose until the follow-up date, which usually we tend to do it on day 5 or day 6 specifically. When do they stop their full mu agonist? In this case, for the sake of example, hydromorphone on day 3. That's it. So first day, 1 milligram QID, day 2, 2 milligrams QID, and stay on that dose. Stop your dilaudid on day 3, and we'll see you in 5 days. Okay? Now, if it's a patient who has an opioid use disorder, we're going to try to achieve better control of their withdrawal just because of the amount itself that they might be using, right? When someone says, like, I'm using fentanyl 1 gram, it may be, it may not. I'm no one to dispute with how much, drug dealers sell their goods out there, okay, but I just need to assume that it's a lot. So definitely I'm going to try to control that withdrawal, okay? So on day 3 for my patients with opioid use disorder, after they have passed from the 2 milligrams QID, on day 3, just take 8 milligrams in the morning, 8 milligrams in the evening, and or 16 in the morning if you prefer. I gave them a choice and we go from there, okay? Now, if I'm dealing with someone who definitely has an opioid use disorder, and even with my patients with chronic pain, okay, one of the first things I ask them is like, hey, now we're transitioning to buprenorphine. Do you still have medication? Because some occasions they come to see me in clinic on the last day of their prescription, right? And let's face it, moving away from something that whether it works or not, but based on your own perception, has kept you from being on intense pain is a stressing moment. And the reason for which I ask that question to my patients on chronic pain is that if they do not have more medication than just for today when they're seeing me, I'm okay with giving them those first 3 days in which I told them the transition is to occur. That's fine, okay? I ask definitely to my patients with opioid use disorder because as well, right? The most common reason for which some of my patients with opioid use disorder may not start buprenorphine is because that situation that we used to tell before, right? You have to be sober from your opioid for 12 hours, 24 hours, whatever the case may be, okay? If not, you're going to go into precipitated withdrawal. These will not cause precipitated withdrawal. Now, if they use any of their supply that still remains at home, will that change my plan? Not at all. And that's why I asked them that question, because I know that if I ask them, look, do you have any more fentanyl at home? Well, Dr. Meza, I do. Okay. Do you plan to use it? Well, usually when they say, well, it means yes. Okay. Just to plain and simple. It's a yes, right? So as I tell them, right, I'm no one to tell them what to do with their life. I will highly recommend for them not to use it. But if they end up using it, do not move away from the plan that we have on hand. It's still going to work, even if they use the supply that they should not be utilizing. Then also I prescribe naloxone, okay? Some occasions I had in a conference, someone asked me, will this work in a residential setting? I'm the medical director of a residential place. Can this be utilized for my patients there? It works. How about hospital settings? I have the blessing to work at UCLA, Ronald Reagan, and also Santa Monica. It works beautifully, okay? Someone can be on a PCA of Dilaudid, and I start buprenorphine 1 milligram QID on day 1, 2 milligrams QID on day 2, without turning off that Dilaudid PCA. On day 3, we turn off the PCA if deemed appropriate on the surgical team's end. No withdrawal whatsoever, so it makes everything way more seamless. How about if someone is on methadone? Do I have to taper, or how about if someone wants to go to methadone? Do I have to transition buprenorphine? Let's say there is one of those patients that more likely benefits from methadone. Not at all, okay? The transition from buprenorphine to methadone is one of the easiest things ever. You just stop buprenorphine, start methadone, end of the tale. Now, how about if I have a patient who is on methadone and wants to transition to buprenorphine? Do I have to taper down on that methadone? You don't have to. Same thing. If you do not have that lag of time in between from the last dose of the full mu agonist to buprenorphine initiation, there is no need to taper anything. Everything can be performed on the same day as long as the dose is appropriate. That's why as you can see, right, it's 1 milligram QID. I'm not speaking of anything above 4 milligrams on day 1. Reason being, receptor occupancy. That's the reason why we created this formula, because we looked at what's the percentage of receptors needed to induce withdrawal and what's the percentage of receptors needed to stop withdrawal. Then I work at a hospital. How long does my patient have to be off IV full mu agonist in order to start buprenorphine? 0 days. Okay, someone is on morphine, maybe was admitted due to cellulitis and will benefit from transition to buprenorphine, and they've been receiving morphine throughout the admission because of their pain for the cellulitis. Same thing, same scheme and all that, okay? So pretty much all this is just to answer the fact that definitely when we have a way in which is reproducible and easy to utilize a medication that more likely we haven't understood quite well, despite all the knowledge that we have yet, you can reproduce it and make it what it used to be, something exciting, right? We with my fellows, we tend to say we made buprenorphine initiation boring. The good thing, if it's boring, is because it's easy for the patient to follow. Okay. Now, definitely another thing that we're exploring more and more, right? All the multiple uses of naltrexone, right? Especially when it comes to the short acting and the long acting implant as well. Okay. As we know, naltrexone is an opioid blocker, okay? It has a really good affinity for opioid receptors, pretty strong, definitely, needless to say. It's definitely stronger than morphine and methadone, definitely more stronger than Norco, okay? And we use it quite often in our clinic, okay? And the current evidence exists for patients with alcohol use disorder, especially those who want to reduce their alcohol intake. It works greatly. We know as well that even allows to achieve sobriety on some of our patients. For opioid use disorder has become more of a second line therapy, especially the injectable. There is not really great evidence in regards to the tablet of naltrexone just because the lack of compliance has been an issue. Definitely is being used now for stimulant use disorders as well. Naltrexone 380 milligrams long-acting injectable plus Wellbutrin, definitely these show really good results in when it comes to reducing the number of days in which people were using methamphetamines. Gambling disorders, there is a really good study going on right now at UCLA, and Dr. Timothy Fong actually is leading that study in regards to naltrexone for gambling disorders. The results right now, they're really good. We still can get it approved just for that as of yet because there is no FDA approval officially for that, but for trial purposes, we know that it can furnish some benefits. There is a way to use it, especially in those individuals in which you have alcohol use disorder and gambling disorders combined, okay? So in those cases, I have a couple of patients in which I have used it myself, and I have had really good results on both conditions, not just one. And then as well, now we start to see low-dose naltrexone being used for pain. Amazingly, an opioid blocker causing analgesia, okay? And reason being is because definitely is noticed that naltrexone at low doses, more than acting on the opioid receptors themselves, is believed that either A, acts on the microglia of the area nearby the neurons that modulate pain, or B, it might have some implications on the opioid receptors, but more than anything, the analgesic effect will occur because of the stimulation of some receptors called TRP. The theory is still being specifically to be explained. We do know that definitely in patients with fibromyalgia, it does help. I have used it myself. It has to be compounded, but definitely it provides really good benefits. Okay, here I have some of my references, and thank you very much for the opportunity.
Thank you so much, Dr. Meza and Dr. Harmandayan. That concludes our talk for tonight. We are very much looking forward to seeing many of you live in Vegas, where we will give a little 15-minute recap of the presentation that we just did. And also what I'm really excited about is Dr. Meza and Dr. Harmandayan have graciously accepted an invitation to be part of our expert panel. Well, you as the audience will also have the opportunity to ask them some direct questions regarding anything you've seen here and maybe some clinical questions that you might have based on the patients that you serve. So thank you again for your attention, and this concludes our presentation.
Thank you.